Hello everyone, my name is Arianna Garza, and today I'm going to be talking about the use of neurally adjusted ventilatory assist in neonatal critical care, and why exactly this mode is an important tool in the neonatal intensive care unit. Neurally adjusted ventilatory assist, better known as NAVA, is a mode of ventilation that can only be used on the servo I ventilators. What makes NAVA so special is that the breath delivery is triggered by the patient's electrical diaphragm impulse, which is referred to as the EDI. The EDI is measured using a specialized EDI catheter, and more specifically, the catheter can measure the strength of the diaphragm's contraction, also known as the EDI peak. It can measure when the diaphragm relaxes too, also known as the EDI minimum. Some advantages of NAVA include improved patient ventilator synchrony, decreased need for sedation, and a normalized work of breathing. The use of NAVA can also reduce peak inspiratory pressures and lower the amount of oxygen required to keep saturations within normal range. NAVA can be used with invasive ventilation and with non-invasive ventilation. NAVA use has been increasing in the neonatal population, especially in those with respiratory distress syndrome. Respiratory distress syndrome is extremely common in preemies whose lungs have not fully developed, and therefore the lungs cannot ventilate properly. Severe respiratory distress syndrome is the main reason for initiating invasive ventilation in preemies. A study was conducted by Mirja Khalil and others in the article titled Neurally Adjusted Ventilatory Assist, NAVA, in preterm newborn infants with respiratory distress syndrome, a randomized controlled trial on 60 neonates with respiratory distress syndrome in the neonatal intensive care unit. The purpose of this trial was to compare NAVA to current standard ventilatory modes during invasive ventilation. Researchers wanted to figure out if NAVA ventilation would reduce the duration of mechanical ventilation. Half of the group were placed on pressure control mode, and the other half of the group were placed on NAVA mode. The median duration of mechanical ventilation in the control group was 25.8 hours. But the median duration of mechanical ventilation in the NAVA group was 34.7 hours. Patients in the NAVA group did in fact have significantly lower peak inspiratory pressures than patients in the control group. Ventilator parameters such as PEEP, mean airway pressure, tidal volume, respiratory rate, and FiO2 were about the same for both groups. Researchers concluded that NAVA is a safe, practical mode for most neonates with respiratory distress syndrome, and NAVA improved ventilator synchrony. However, NAVA did not reduce the duration of invasive ventilation when compared to the control group in pressure control mode. Non-invasive ventilation is another tool used to treat respiratory distress syndrome. It is preferred over invasive ventilation due to the risks that come with invasive ventilation, such as bronchopulmonary dysplasia or pneumonia. Several small studies have evaluated the effects of non-invasive NAVA on neonates. However, one study discussed the effects of NAVA on premature infants with respiratory distress syndrome specifically. The article titled Non-Invasive Neurally Adjusted Ventilatory Assist in Preterm Infants with RDS Effect of changing NAVA levels, published in the European Journal of Pediatrics, detailed a prospective, single-center, interventional exploratory study on 12 preemies. NAVA level is a value set by the respiratory therapist, and the factor that converts the EDI signal into a proportional pressure is the NAVA level. If the NAVA level increases, then the patient's work of breathing will decrease because the ventilator will provide greater support. The break point is the point at which the NAVA support is at a level where the patient's diaphragm is adequately unloaded. The purpose of identifying this break point is to help establish ideal settings for NAVA in this specific population. Julie Lefebvre and other researchers organized their study to investigate if a breakpoint could be determined in preterm infants in the early phase of acute respiratory distress syndrome on non-invasive NAVA. To determine the breakpoint, researchers started at a NAVA level at 0.5 centimeters of water per microvolt, then titrated the pressure by 0.5 centimeters of water per microvolt every 3 minutes, up to a maximum level of 4 centimeters of water per microvolt. The changes in peak inspiratory pressure and EDI during titration were measured. They determined that as they increased the NAVA level, the preemie's respiratory rate would reduce. Observation revealed that the average break point was a NAVA level set at 2.33 centimeters of water pressure per microvolt. It is notable that this break point is at a higher NAVA level than the level typically set in this clinical situation. Increasing the NAVA level is known to increase peak inspiratory pressures. However, this study proved that after reaching the NAVA breakpoint level, the peak inspiratory pressures did not increase from there. Not only is non-invasive NAVA being used with preemies with respiratory distress syndrome, but it is also being used on preemies as a mode of respiratory support after extubation. A research article published by the Journal of Pediatrics titled Non-Invasive Neurally Adjusted Ventilation and Post-Extubation Stabilization of Preterm Infants, a randomized controlled study, further explored the effects of non-invasive NAVA on neonates. Researchers Shun Han Shin and others performed a prospective single-center randomized controlled trial on 70 preterm infants to compare the effects of nasal CPAP on non-invasive NAVA in preventing extubation failure. These 70 preterm infants were extubated because they met extubation criteria for at least 6 hours. The extubation criteria was met if the infant had a peak inspiratory pressure less than or equal to 16, and if the infant had a respiratory rate less than or equal to 25 breaths per minute, and if the infant's fraction of inspired oxygen was set less than or equal to 35%. Results showed that extubation failure within 72 hours was significantly higher in the nasal CPAP group when compared to the non-invasive NAVA group. Almost 28.6% of preterm infants in the nasal CPAP group had experienced extubation failure, while only 8.6% of preterm infants in the non-invasive group had experienced extubation failure. I believe that it is important to note that the rates of bronchopulmonary dysplasia and the duration of respiratory support were similar in both groups. Overall, researchers determined that non-invasive NAVA was more effective in preventing extubation failure in preterm infants than nasal CPAP. Researchers supported the idea that a decrease in work of breathing is an advantage of non-invasive NAVA compared with nasal CPAP. So with all that said, I want to thank you for taking your time to listen to my presentation on the use of NAVA in the neonatal critical care unit, and I hope you found this presentation to be informative and engaging. Goodbye, everyone.